Hello everyone, I am Sujatha. I am a professor of sociology at Jawaharlal Nehru University, New Delhi, India, and I am very pleased to be part of this panel on human centered values in the healthcare bureaucracy. And it's a timely and most appropriate theme, especially after the pandemic. And my presentation in this panel is on humanism and the healthcare bureaucracy, dealing with asymmetry and inequality in health communication. In my view, there are two major challenges faced by the modern healthcare system. They are asymmetry in the knowledge of the doctor and the patient. Secondly, inequality in the socioeconomic status of the doctor and the patient. That is the gap in the socioeconomic status between the doctor and the patient. So, in this presentation, which will be divided in three parts, I will engage a little bit with these two major challenges, dwell on the approaches and philosophy of medicine that have responded to the problem of humanism in healthcare, and thirdly, bring to the table a few examples based and from different perspectives to the problem of humanism in healthcare in the Indian context. Firstly, let's go to the challenges. The modern healthcare system, especially that provided by the government, has continues to face two major challenges. One is intrinsic to biomedicine, which is an expert-centered of medicine, expert-based system of medicine, and it is the asymmetry in the knowledge between the doctor and the patient. It's because the patient has experiences the disease, is suffering from pain, and the doctor has knowledge of the disease and the expertise to cure it. So this asymmetry is there in any system of medicine, that the patient experiences the disease and the doctor has the expertise to cure it. Now, in biomedicine, it is particularly acute because it has become increasingly technology centered and highly advanced, highly specialized, where particular parts and subclinical entities within the body are being focused on, and the total person is being lost sight of. Secondly, also the lived experience of the patient and the patient's symptoms occupy less and less important space in the diagnostic process, which is largely based on numerical parameters of physiological processes or of images and other test results independent of the patient's symptoms. So, this could lead to a situation where the patient finds that his or her suffering or lived experience is not being heeded to by the doctor, who relies more on the technological inputs about the patient's body without paying attention to the experience of the patient. This is particularly acute if you look at end of life care in an ICU, which is highly medicalized. And so there's a lot of work on medicalization of death, where end of life patients are completely controlled in the ICU. They are cut off from loved ones and under the control of technology and medicine. Second problem is one of inequality. This inequality can lead to a gap in the socioeconomic status of medical care providers, which includes the physicians and also the paramedical staff and the patients. Generally, the people who seek healthcare from government facilities are people from resource poor backgrounds, women and children who might need help, vulnerable sections, migrants, people from indigenous communities, daily workers, etc., who would like to access free medical treatments. They are also the sections that suffer from dual burden of communicable and non-communicable diseases. But the doctors and the medical staff come from stable socioeconomic backgrounds, and for them this process is sort of routinized. So this gap can lead to certain bureaucratic hurdles. They are of three kinds. Firstly, it can be direct and simple indifference or harshness towards the patients. This is often noted while people from other racial communities or members of indigenous communities, socially disprivileged communities, or simply poor background they are treated harshly, not provided the required information. They are, or they at best might be treated in an indifferent way without dignity and respect. Secondly, the problem is sheer administrative regulations of the hospital, such as having to deposit money or having your documents, having should have had prenatal care to avail the delivery facilities. So, and that the patient should come from the same jurisdiction of the healthcare center, or they might be sent to another place. And in this transit, the patient may suffer or often even die. This happens very often in health centers, which send patients away saying that they should go to another district hospital. Thirdly, and most importantly, is the problem of social accessibility. This means that even if a government facility is physically available and also is economically accessible in providing free medical care of reasonably good quality, it is socially inaccessible because it involves lot of waiting time. Many good, high quality government facilities, even if they are present, are not sought after by daily wagers because going there and getting treated would involve losing a day's wages, because the waiting time and the bureaucratic procedures are quite cumbersome, and they would rather go to a chemist shop or an unqualified practitioner and collect medicines. So this makes government facilities socially inaccessible also because of the huge burden of patients under outpatient care that they are treating. So these kind of issues lead to problems in health communication. Within philosophy of medicine, the focus, however, has not been on healthcare system or inequality. It has been more focused on the interpersonal relationship between the doctor and the patient. And in philosophy of medicine, the biological reductionism of biomedicine has been criticized. It has been pointed out that the doctor patient relationship is very cold, it is objectified. The patients, the technological sophistication tends to lose sight of the patient as a whole person, and there is a tendency to always be interested only in the disease and not in the patient as a person. And there is less of listening, and there is very less sensitivity to the socio-economic situation of the patient. There is very little empathy in this clinical encounter. These are the kind of criticisms that have been made, and the field of narrative medicine has emerged to bridge this gap, basically involving training doctors to listen and to themselves construct narratives of the doctor patient encounter. And this, the votaries of narrative medicine argue, has improved empathy. That is by making doctors write journals about their encounters with the patients and others, and make diary entries and discuss them, has led to a situation where their empathy increases, their patience towards patient and listening to their narrative has improved. So such workshops continue to be conducted, and in the private sector, they have definitely led to a greater empathy and care to patients who can provide money. But our concern here is with the government health facilities. So we have to go beyond the interpersonal relationship between the doctor and the patient, which nevertheless has improved over the years. And but whether such condition inheres in the government health facility is something that we need to be concerned with, because the interpersonal relationship is very important to ensure that the patient not just gets cured but also gets healed. This is one of the claims made by narrative medicine people, that the doctor should also heal. In this respect, I want to draw your attention to a very interesting study by an anthropologist, Daniel Moorman, in 2002, titled "Medicine, Meaning and Placebo Effect," where Moorman is looking at clinical trials and examining the control group in clinical trials that receives placebo. It's understandable that the experimental group gets cured and improves. But very often in the clinical trials, 40 to 60% of the participants in the control group who receive the placebo also get better without the medicine. So, how is this possible? Moorman called this meaning effect. He said that the whole idea of participating in the trial, being cared for, being attended to, receiving medicines, and being monitored actually brought about a positive effect, not just psychologically, but also had a physiological effect that improved the outcome of the treatment. So, this clearly shows that the meaning and the concern of the treatment matters in outcomes. And as the votaries of narrative medicine have pointed out, it is not only a moral necessity for the doctor to pay attention and show empathy to the patient, it also reduces neglect, it reduces error in treatment, and improves the outcomes of the curative treatment. While this is as it may be, I have to move to the third section and show how humanism in healthcare has to go beyond the interpersonal relationship between the doctor and the patient, especially in the healthcare bureaucracy. Because in private sector these benefits may be available, but is it available in the government sector? So I want to draw your attention to two experiments in the public health care delivery in India. One in the civil society sector to address the problem of inequality, and the second one to address the problem of asymmetry. Let me take the first one, the problem of socioeconomic status of the patients, especially vulnerable patients. Several initiatives to improve the access by involving community health workers have been done by the government facility. But what is important is that this is based only on vertical programs and specific reproductive health programs. Civil society initiatives are crucial to expand the horizon of public health care by going into the larger context of community problems such as nutrition, level of education, and so on. So, Jan Swasthya Sayog is a civil society organization started in 1996 by a group of highly qualified medical professionals from All India Institute of Medical Sciences. They felt that medicine should be directed to poor people who living in remote areas. So they felt that the biomedical knowledge is valuable, but the issue of humanism arises in the healthcare delivery, the way it is delivered to people. So they went to a remote area and set up a clinic, and in these 25 years, they have developed a full-fledged community outreach program, which includes nutrition and education and a host of other problems in which the community is involved. And they have succeeded in providing low-cost, high-quality, community-based healthcare, and have created a role model which could be replicated by the government sector. So innovations cannot be made fully from the government sector itself, which is ridden by bureaucratic hurdles. But civil society is a domain where innovations can be made. And one remarkable aspect of the Jan Swasthya Sayog is that they have introduced appropriate technology in healthcare. A lot of medical technologies are expensive or inaccessible in resource poor areas. So, Jansastya Sayog has introduced the idea of appropriate technology by developing good quality testing kits using simple material. So they have a copper sulfate based anemia testing kit. They have developed first aid testing kits. They have developed breath counters. All these things using a simple cost effective material, and these testing kits are also available for distribution in other parts of the world. So appropriate technology, they could make biomedical care available to the poorest of poor people, and this is a set of altruistic set of people. So civil society can develop innovations is the point here. The second experiment I want to mention is that while the asymmetry in knowledge between the doctor and the patient that we started with, can be addressed by better communication. Patients, especially from resource poor backgrounds, should have the option of opting for holistic or other treatments which offer them a better effectivity. So, medical pluralism, which is a policy by which non-biomedical systems, alternative systems, and traditional medical systems are brought into the government healthcare and made available like biomedicine free of cost to the people, will be a huge step towards promoting humanism by way of giving them the choice to opt for curative care of biomedicine for certain ailments and opt for more holistic treatment for chronic ailments. This facility of medical pluralism is available in the private sector for the rich people. The what I'm suggesting now is making it available in the public healthcare. And the government of India has created a separate ministry called the Ministry of Ayush, which is an acronym for Ayurveda, Unani, Yoga, Siddha, and Homeopathy, which are being offered in the government health services. Though there are several limitations in bringing in holistic systems within the health bureaucracy, that such that they might lose their holism. Nevertheless, these problems could be addressed, and medical pluralism as a policy will help address the problem of asymmetry better. So, I wish to conclude by pointing out that humanism in healthcare, especially in government healthcare, has to start with the interpersonal relationship between the doctor and patient, but has to extend to the health staff, paramedical staff who also have to be trained to provide humanistic care. And thirdly, extend to healthcare policy, bringing medical pluralism in, and to healthcare delivery, where civil society role models have to be imbibed in the government healthcare. Thank you.